You can start.
Good morning, respected sir and my dear colleagues. Today we are going to discuss about the few blood culture isolates that we got in the last 1 week. So this is the first case. This is a 46-year-old male who is a hotel worker by profession with past history of rheumatic heart disease. At the age of 15 years, he had some polyarthralgia, fever, sore throat and like that. So he had investigated and he had taken 5 years of penicillin. As per patient he had taken, after that he stopped by himself. So in the year of 2016, he developed chest pain, dyspnea, bilateral pedal edema. For that he was undergone investigation and found out that some aortic valve damage was there. That time AVR, aortic valve replacement with the bioprosthetic valve replacement was done on 2016. After that the patient was on ecospirin and carvedilol, and 1 year he had continued acetram. After that it was stopped because it's a bioprosthetic valve. So now the patient presented to our medicine department with left-sided chest pain which was radiating to the left shoulder and neck and associated with fever for 25 days duration. And also he had a history of hypertension for 4 years on telmisartan. And personal history, he had history of chronic alcoholic from the age of 10 years and pan-fever from the age of 10 years. So on examination, patient is having features of pallor, and cardiovascular system examination also, JVP was elevated and ejection systolic murmur was present at the aortic and mitral area with a grade 4. That time with the patient is having fever, previous rheumatic heart disease history was there on irregular medication, and one aortic valve replacement was done on 2016. And with this fever history, definitely, and systemic examination findings also definitely pointed out to some infection which was originated from cardiovascular thing. So they had sent the basic investigation, CBC, ESR, renal function test, LFT and other parameters, ECG, echo and everything done. This was a fever chart. You can see the fever spikes during the admission. So the total count was slightly elevated. It was around 13,000 with a neutrophilic predominance, and absolute neutrophilic count was also elevated. The C-reactive protein during the admission was 100 and procal was also elevated. It is around 18. So you can clearly, started some antibiotic empirically, that is ampicillin and gentamicin. They started empirically in view of they are thinking about some prosthetic valve was there, so prosthetic valve IE they started, but they clearly mentioned one good thing. That's why I included that particular page. After taking 3 sets of blood culture set, they have to start antibiotic empirically. That clearly mentioned. So they had sent the IE protocol, 3 sets of blood culture they have sent to our lab. This was the echo done during the admission. So in the echo, there is no peculiar vegetation was there. Aortic prosthetic valve was there and some aortic valve leak was there. So they further advised transesophageal echo. The TEE was also negative, and further they told about the SPECT-CT for further evaluation. So blood culture, total 6 bottles, all came positive in our laboratory. So we got Streptococcus, gallolyticus from all 6 bottles. So in previous 2 cases were there, we discussed what is the diagnostic disparity in between Streptococcus mutans and gallolyticus. So it is this gallolyticus coming under bovis group. So we have to differentiate these two by doing esculin, arginine and other biochemical reactions and the other features. So this is coming to be Streptococcus gallolyticus. So this patient, they have empirically started ampicillin and gentamicin. So gentamicin they started 3 mg per kg per day, and ampicillin also as QID doses they have started. So after the report, they continued the same regimen for this patient. So this is the modified Duke's criteria of 2023. We all know it is having major criteria and minor criteria. So I included this peculiar slide. Why? Because we got the major criteria, 2 things will be there. That is, one is blood culture positivity, other one is echo, PET scan or SPECT scan. That means in 2023 rather than 2015, they have included the PET-CT, SPECT-CT and other investigation to rule out the vegetation. So in this patient, the echo findings are negative. That we know transesophageal echo is having a specificity and sensitivity of more than 90%, but this patient, they didn't get any vegetation in TE also. So they are waiting now for the PET scan. Why? Because if any vegetation is there after fasting, this increased uptake will be observed in PET and SPECT CT. So in this, blood culture came positive but the echo is negative. They are waiting for PET CT. So these are the criteria we know, that is either 2 major should be there or 1 major plus 3 minor should be there or 5 minor should be there to tell it as a confirmed infective endocarditis. This patient, already the blood culture, all 6 bottles flagged positive, and the minor patient is having fever, previous history of prosthetic valve and valve replacement was there, and some here there is no immunological phenomena, PET CT is not matching, and new regurgitant murmur is there. Previous admission there is no mentioning of any murmur. After admission we got grade 4 murmur. Initially it was grade 2, then progressed to grade 4. So we can consider as a minor criteria. So here 1 major plus 3 minor is fitting for this patient, but the echo is negative. So these are the criteria we already discussed. So these are the ESC guidelines to treat Streptococcus bovis or gallolyticus. We all know the 4 important organisms, that is a typical organism causing IE. So for that, either we can use 2 tables are there, either we can use penicillin or amoxicillin or ceftriaxone based monotherapy. So if it is a native valve, we have to give for 4 weeks. Prosthetic, we have to give for chronic duration 6 weeks. This is one regimen. Other thing in the table 2 they mentioned us, we have to combine. That means ampicillin plus gentamicin like our case, but the gentamicin duration should be 2 weeks only. Like that we have to give, but the dose is here. Sir also while reporting we discussed, that is gentamicin normally we will give 7 mg per kg per day, but here it is mentioned as 3 mg per kg per day along with ampicillin. So some articles are telling that if you are giving in this IE patient, there is a higher chance of getting nephrotoxicity, because IE induced this renal thing will be there, so it will induce. So that's why they are included 3 mg per kg dose of gentamicin in this particular combination regimen. In our patient, they are giving AmpB plus Genda. Why we are not giving rifampicin in this case? It is one other question, because this patient is having prosthetic valve. So if the patient is having prosthetic valve, the guidelines are telling if it is within 1 year of the prosthetic valve surgery, we have to give, along with that we have to add rifampicin also of 600 to 900 mg per day. But here 2016 only the patient had undergone surgery, more than 10 years. So we didn't add rifampicin according to the ESC protocol. So if it is patient is not tolerating or resistance is there, we have to go for higher antibiotics like vancomycin plus gentamicin combination. What is next? So this patient, blood culture got positive. They have started on AmpB plus Genda regimen. Echo they didn't get anything. They are waiting for PET CT. So PET CT definitely they have to do. The focus of infection we have to clearly mention. Patient is having prosthetic valve. We got Streptococcus gallolyticus. So last blood culture which also we discussed, gallolyticus is there. Some GI source we have to rule out in that patient. So many studies are there. If one study in Egypt, it was there that they have screened patient, normal patient and the patient with some colorectal carcinoma. So in patient with colorectal carcinoma with bloodstream infection with gallolyticus, the chance of getting IE is around 25 to 80%. That is wide range is mentioned in that study. So definitely they have to rule out the PET CT whole body to rule out whether it is prosthetic valve or any other focus there. Definitely they have to rule out. And next thing is colonoscopy. They are planning to rule out, and fundoscopy, definitely the IE features like a rod spot or anything, we have to, fundoscopy of this patient was already done. It was nothing suggestive of rod spots, so nothing was there. And next one is we are giving gentamicin. We all know it is having nephrotoxic potential, so we have to look for the renal parameters. So these are the patients. During admission the creatinine level was 1.3 and other things was also normal. After starting gentamicin also the creatinine level is okay only. So these are the scoring system. In our hospital we are having TE, TOE, TTE and PET scan facility now. If you are in a hospital with the patient is having some bloodstream infection with the Streptococcus, Staphylococcus or Enterococcus bloodstream infection, we have to predict the role of echocardiography by some scoring system. So we got Streptococcus in this case, that is hand-hook scoring system is there. Hand-hook scoring system, that means heart murmur or any valvular disease is there, we have to score it as 1. In our case, it is clear that patient is having a valvular disease and heart murmur. So score 1 we can add. Etiology, we got Streptococcus bovis group, that is gallolyticus. Again 1 score will be there. Positive cultures, we got 6 bottles positive. So again 1. Duration of symptoms, definitely patient is had fever of more than 25 days coming at 1, and only one species isolated 1, community acquired 1. So this hand-hook scoring system, if it is more than 3 means definitely echo and other thing we have to do and rule out the particular foci of infection. If it is less than 2 with bacteremia of this particular species, we can wait. That means echo is not urgently needed. So this is a scoring system for Streptococcus. Like that, Staphylococcus and Enterococcus faecalis scoring systems were there to predict the need of echo and other investigation to confirm I. So these are some publications, that means Streptococcus gallolyticus associated with colorectal cancer in patients. That means the patient is having some colorectal malignancy, or if we are getting some Streptococcus bovis or gallolyticus in blood, definitely we have to rule out colonoscopy to rule out any rectosigmoid lesions and other things. These are 2 trials we already know. One is a POET trial. The other one is not a trial, it is OPAT based regimen. So POET trial, that means in left side infective endocarditis with the Streptococcus species, Enterococcus and Staphylococcus, after 10 days of IV therapy, we have to repeat the echo. If the echo, the vegetation is decrease in size or vegetation is gone, we can shift to oral based regimen. That is a POET trial. But it is a specification is there. That is, if it is left sided IE with the particular organism only, we can go for this POET trial. This is a OPAT based regimen. In our previous one case also, after the successive therapy of the 2 weeks, that means a prolonged hospitalization itself induce some hospital acquired infection to the patient, and the cost of that hospital admission also increases. So in that cases of IE, this is an OPAT based regimen. It is not a trial, it is a based regimen. After successive treatment, we can discharge the patient. The patient can take IV therapy from the outside hospital for IE. So this is the first case. The patient is now also on our ward because the PET CT is pending, and the IV therapy after 2 weeks, 7 more days is there for gentamicin. After that, they will stop gentamicin and continue the other therapy for 6 weeks, total 6 weeks, because it is a prosthetic valve infective endocarditis. And blood culture also, repeated sample was sent. It was not flagged yet.
This is prosthetic valve?
Yes, sir. Okay. Aortic valve replacement was done, sir. Bioprosthetic valve.
Okay.
Coming to the next case, this was actually a very interesting case. That is 43-year-old female who was diagnosed how RVD positive 6 years back. Her husband was also died due to RVD. 2 kids were died due to RVD positive and related sequelae. So she had diagnosed 6 years back and started on TLD regimen, that is tenofovir lamivudine dolutegravir based regimen. She is compliant to medication, and 1 year back she had started cotrimoxazole due to this opportunistic infection prophylaxis. Cotrimoxazole was also added to the therapy. So for the last 6 months, she was having severe abdominal pain, loss of weight, fatigue, dysphagia. For the last 6 months, she was consulted multiple hospitals outside. So she came to our hospital with abdominal distension, loss of appetite is there, melena and vomiting for 10 days duration. So on examination itself, patient is looking, wasting is there. On examination, a 5 into 5 centimeter mass in the epigastric region is there, and patient had fever at the time of admission, and USG abdomen was done. So a space occupying lesion in the epigastric region, probably a mass, chronic organic cirrhosis, mild ascites was there, mild splenomegaly, and features of portal hypertension is also there in USG. So they had taken a USG guided biopsy, which shows the immunofluorescence of the biopsy was also done, which was positive for synaptophysin and chromogranin, and CD35 was also positive from the biopsy. So they had done the CECT. CECT shows soft tissue mass enhancing the epigastric region, left hypochondrium and left lumbar region. Large mass was there. PET-CT was also done. The same area, large lesion with enhancement was present in PET-CT also. So the biopsy that chromogranin, synaptophytes and all are suggestive and positive, which shows a presence of neuroendocrine tumor in this patient. So due to this retropositive and the patient is having pancytopenia also. Why? Because the patient had taken double strength cotrimoxazole orally for the last 1 year. So in the duration time of admission also she had pancytopenia picture also. So they didn't do any surgical management for this patient. Patient admitted on 19 January in our hospital. She was in ICU. So after the admission she developed ascites, moderate ascites and mild pleural effusion. For that pulmonology consultation was also done. Ascitic tap was performed. The ascitic tap, which is mainly lymphocytic predominance only. Culture was also sent. Culture was negative and pleural tap also they have tapped. But the pleural tap and the X-ray also show some consolidation in the lower lobe when the pleural effusion presented. So that pleural effusion, that it was exudative in nature, Light's criteria is fitting into the exudative nature, and the pleural fluid culture, but we didn't get anything, but it is mainly neutrophilic predominance. And that time the patient started on piperacillin tazobactam. After that only they had sent blood culture and pleural fluid. So from blood culture, 2 bottles ideally we will send, one aerobic and one anaerobic. From the 2 bottles flag, from the anaerobic bottle flag we got Streptococcus pneumoniae, and from the aerobic bottle we got Haemophilus influenzae. So we can understand how it happened, and this patient we went and see what is the thing, from what is the source of this infection and all. The patient is already immunocompromised, RVD positive, CD4 count is less than 100 for this patient, and the viral load is also high. And this patient, the lung involvement is there. Initially the chest X-ray was looking normal only. So while the patient developed pleural effusion, the X-ray findings lower lobe consolidation was there, and the pleural fluid is also exudative in nature. So they had started PIPTAS with cotrimoxazole and TLD only. We got blood, the anaerobic bottle we got Streptococcus pneumoniae, which is penicillin susceptible only, and these are the Haemophilus influenzae chocolate agar picture we got from the aerobic blood culture bottle. But this patient, even after starting piperacillin tazobactam and the other thing, the patient had pleural effusion, ascites and multi-organ dysfunction syndrome with the pancytopenia. They are suspecting HLH also in this patient, but they didn't add any steroids because the CD4 count is low, this much of infection is there. The patient succumbed to death due to the itself RVD related complication as well as MODS and the infection. So this scenario, if we are getting 2 organisms from a blood culture, definitely we have to look into deep the history of the patient and other examination findings, and the source of infection also we have to rule out. In this case, we have to report these 2 bugs, because the 2 bugs definitely there should be a competition to exist in the particular area to cause the infection. The patient immune system is so weak, definitely this both will be the culprit of this particular. Maybe the source will be this lung only, sir. So these are some article. That means in this old articles only I found out in Google Scholar, that is in 2020 some studies are there. That means in HIV initially the treatment, the patient did not get proper treatment during that time. So many Haemophilus influenza related sepsis and other meningitis cases were there. But nowadays due to the vaccination of influenza, Haemophilus influenza and the proper TLD regimen, the chance of infection is less. But even though non-typable strains of Haemophilus influenza is causing some infection in HIV patient with a low CD4 count. Coming to the third case. Third case, it's a 22-year-old male. He had history of persistent diarrhea. That means for the last more than 20 days he had history of persistent diarrhea associated with high-grade fever and chills and vomiting. For that he had consulted outside hospital and took some antibiotics, but the data is not available. He came to our hospital and he complained of bloody diarrhea. The patient is telling bloody diarrhea. But while seeing that the bystander is showing some pictures of that loose stools and all, it is looking like greenish water diarrhea only, it is not blood stained. So during admission the patient is having fever, persistent diarrhea is there. They are thinking about so many DDs will be there. Bloody means we will think about dysentery like thing. So in the emergency, they have started this patient with the IV ciprofloxacin and metronidazole for this amoebic coverage. They have added metronidazole also. So even after starting these antibiotics also, the patient is having further fever spikes was there, patient is having fatigue, severe abdomen pain was there. So they had, during the admission only, they had sent the blood culture. Yesterday morning, the blood culture bottle flagged positive. So the gram stain is looking like a pleomorphic gram-negative bacilli. So Dr. Parvati called me, this is a pleomorphic bacilli. So we are thinking about this patient is having persistent fever and diarrhea is there. Definitely the first thing come to our mind is enteric fever is the DD, because that much of duration is there, patient is toxic, high grade fever is there, like that. So that blood culture we did the direct sensitivity and subculture from that, and the direct sensitivity by evening we got, which is ceftriaxone sensitive. The patient is not improving with ciprofloxacin. Yesterday they changed to escalated to ceftriaxone 2 gram IV BD. So today we have to further evaluate the particular thing, but by direct sensitivity test from this blood culture, it shows sensitive to ceftriaxone only. This patient is having more than 20 days diarrhea. So he also developed dehydration or pre-renal AK is there, acute kidney injury is there. That part also they are evaluating in this patient. This is the last case. That means this patient actually. Along with this patient, I will discuss one other case also. This 44-year-old male, he's had history of hypertension on treatment for last 5 years. He is taking telmisartan 40 mg daily. There is no history of diabetes or any other past hospitalization, nothing when we are asking to the patient. So now present with a fever, left low into groin pain for 4 days duration. That is a presenting complaint. Fever was high grade with associated with chills and rigor. So on admission, they have done the complete blood count. The complete blood count, the total count is around 14,000 with neutrophilic predominance. Urine routine examination was also done, which shows plenty of pustules and bacteria was there. So renal angle tenderness was also there in this patient. Definitely with these features, we will suspect pyelonephritis feature from the symptom, examination findings and other basic things. So they have started this patient on initially they have started on ceftriaxone, but even after starting ceftriaxone, the patient is not improving. Blood culture also definitely they have sent. USG abdomen was done, POCUS was done, and which shows perinephric fat stranding, which suggests you pyelonephritis. So in looking at the URE, the presence of sugar was there. So we repeatedly asking whether any diabetes history is there. He is telling no, like that. So we had sent HbA1c also. HbA1c came as 11 in this patient. So patient is a de novo diabetes case presented with the pyelonephritis. So blood culture also sent. This is a urine culture report we got, which is a ESBL AmpC producer, which is susceptible to piperacillin tazobactam. So after getting the report, they escalated from ceftriaxone to piperacillin tazobactam 4.5 gram IV TDS extended infusion they have started. Blood culture also we got the same thing. So they are continuing pip-taz. Not combination of pip-taz genda, they are continuing piperacillin only, and the diabetes part also they are started some oral hypoglycemic agent for this patient, but it is sugar level is controlled. That means prior to food and after food and also it is controlling. That's why they didn't add insulin to the treatment. So they are giving that piperacillin tazobactam only.
Monotherapy.
Monotherapy only giving, sir. Clinically patient is improving. Repeat blood culture also sent for this case. So next to this
means both systemically and pyelonephritis.
Yes, sir. Next to this bed, one 26-year-old boy is there. Same complaints, but there is no history of diabetes, no history of hypertension, nothing. He is having right side only. That is the only difference. He had fever also.
So this again goes against a merino. Giving peptazo for an ESBL AmpC co-producer and giving us 4.5 gram in your PKP dosings and patient is improving. So that again rules out that if you are giving as a bolus dose, it may not be effective, and that's what they might have been using in this thing.
So next patient to this one is young boy with features of pyelonephritis. That patient also urine culture they have sent, blood culture also they have sent. That also Escherichia coli we got, which is only blood culture we only, that is only isolate is only sensitive to carbapenems. That patient initially started on piperacillin tazobactam, not improved. Then they added gentamicin along with that, again not improved. Then escalated to meropenem 2 gram IV TDS in that case. But what happened to that patient is the fever subsides, sir, but the patient now suspected of some IRGN features, infection related glomerulonephritis features, because the patient is having hematuria, pedal edema is there, low complement level is there. So initially the patient presented pyelonephritis. After giving initially Piptas Genda, and then converted to Miro. So now the patient landed into IRGN. Maybe that bug is also resistant to Piptas and all. So the reason don't know, but these two patients are same with clinical features pyelonephritis, given 2 based regimen. One patient, young patient only, without any comorbidities, landed into IRGN. So these are the importance. The Merino 1 trial is telling the 30-day mortality as comparison to Piptas and Miro. But when we are giving to the patient, according to the patient, it may vary with various factors. So these are the 4 cases. The remaining cases Nigel will discuss.